Welcome, everybody. We are going to go ahead and get started. Thank you so much for joining today's virtual symposium, Immune Dysregulation, What is it and what is it not? A few housekeeping items. First off, everybody attending will get a link to a survey at the end of this event. Those claiming CME credit, please complete that survey so your certificate can be auto-emailed to you. This survey will remain open until close of business on Friday, November 6th. But we urge you all to complete it as soon as possible. Secondly, please post questions as you have them in the Q&A section on the right of your screen. We'll be getting to these questions at the end of the lecture, but we encourage you to ask them throughout the presentation. Thank you all again so much for attending, and now our program manager for immune dysregulation is going to introduce today's speaker.
Thank you. Dr. Edward Behrens received his undergraduate training at the Johns Hopkins University, where he majored in biology. He then attended medical school at the University of Pennsylvania, where he received the prestigious Howard Hughes Medical Institute's Medical Student Research Fellowship to train in the laboratory of Dr. Philip Cohen. After medical school, Ed then completed a pediatrics residency and pediatric rheumatology fellowship at the Children's Hospital of Philadelphia. He performed 2 postdoctoral fellowships in the laboratories of Stefania Gallucci and Gary Koretsky, after which he joined the faculty of the Division of Rheumatology at CHOP as an assistant professor in 2009. Ed's research interest is the pathogenesis and treatment of cytokine storm syndromes, including the hemophagocytic syndromes, hemophagocytic lymphohistiocytosis, HLH, and macrophage activation syndrome, MAS. These are uniquely pediatric immunologic conditions that result in severe systemic inflammation and death if unrecognized and untreated. Despite current therapies, mortality remains high for these conditions, hovering around 50% of patients. Ed has developed a novel murine model of MAS that has allowed the careful immunologic dissection of the mediators of disease. More recently, Ed has begun to work on novel mediators of HLH and is developing a new immune modulating therapy to treat this disease. His work has been recognized with many awards from the American College of Rheumatology, the Histiocyte Society, and the Arthritis Foundation. He is the founding member of the International MAS Study Group and has given lectures internationally on MAS and HLH. So without further ado, please join me in welcoming Dr. Ed Behrens.
Okay, thanks for that introduction. And we're going to talk today about what immune dysregulation is and what it isn't. And this is a somewhat tough lecture to put together because I think everyone's conception of what this is and isn't might be different depending on how you trained and some sort of from what perspective you're coming from. And when we were first putting together these slides, we were thinking about the generalist trying to identify immune dysregulation and referring to subspecialty care. And as we noticed that there was a lot of interest from subspecialists of various disciplines, I've tried to include a little bit of everything for everybody. So hopefully everybody will find something of interest the lecture, and certainly I think in the Q&A section we can certainly dig deeper into the things that that are of interest to the attendees today. So we're going to go over sort of how we conceive of immune dysregulation, what we think it actually is, some of the common conditions that we consider in our immune dysregulation clinic here at CHOP, talk a little bit about the benefits of the multidisciplinary approach to these diseases, diagnostics that we use, spend a little bit of time on what it is not, and in many ways, what I've come up for with what it is not is based upon the alternate diagnoses that we see in clinic when cases are referred to us and we say, well, your problem isn't immune dysregulation, but there's really something else going on. And then talk about what one should do if you have a case that you think is immune dysregulation. Where should that patient be referred? What's the most effective way to get care? All right, so I think the philosophically, this idea of immune dysregulation really speaks to the fact that the immune system touches everything, right? So you have a whole bunch of different effector arms of the immune system, T cells and B cells and antibodies and neutrophils and so on. And those elements patrol and interact with every tissue, every surface of the body. So the potential for the ways in which you can present when the immune system goes awry are almost limitless. You can look like a rash. You can have fever. You can have joint pain. You can have bleeding because your platelets don't work. Maybe it affects your lungs and you have shortness of breath. Maybe it's affecting your liver. Maybe you're just having recurrent infections because you can't fight off the pathogens that are attacking you. Sometimes it presents with autoimmune features. So you make antibodies against self tissues. Maybe you're just presenting with malaise, and all these things are sort of running together, and it's a very confusing picture. And when one takes a step back and tries to find a unifying cause for all these sort of diverse features that a patient might be presenting with, you realize that there's a fundamental immune dysregulation problem going on. And that makes it difficult to diagnose because it can present with a whole host of different features. Sometimes you have some and sometimes you don't have others. Sometimes you have all of them. And you don't always necessarily have the immediate clue as to what your handle is in terms of what's wrong with the immune system, or if there's anything wrong with the immune system that's driving that diverse array of symptoms. Now, the way that medicine philosophically has dealt with this in the past is putting things in the silos, right? I mean, that's medicine is very good at that. Find a box, put something in that box. So we can do that by naming different immune states or immune conditions. And so that's what's on the left-hand side here. So we can talk about autoimmunity, which is loss of tolerance. We can talk about autoinflammation, which is a loss of control of immune effector functions, but without any necessary loss of tolerance. Lymphoproliferation, which is an expansion of immune cells, giving you big lymph nodes and a big spleen. Immunodeficiency, atopy, paraneoplastic syndrome, cytokine storm, right? So we would box things up on the basis of how we thought about what was the problem of the immune system that was most going wrong. And then perhaps, sort of even older than those ideas are sort of all of the ologies. You've got a rheumatologic condition, you need to see a rheumatologist. You've got an oncologic condition, you need to go see an oncologist, so on and so forth. And that only works as well as you have only one problem that subspecialist is trained in. And I think what has become more and more apparent is that there are some things that overlap. Now, there are things that really remain crystal clear, right? Like lupus is always going to be best cared for by a rheumatologist. If you have SCID, you're going to be cared for by an immunologist. If you have leukemia, clearly you need a cancer doctor, right? So this isn't to say that all things need this big multidisciplinary approach, but there are definitely things where there are overlaps where you can bring in expertise from different subspecialists that can contribute to the care of a patient in a way that you just can't get from being boxed into these traditional silos. So for instance, there are many patients that have common variable immunodeficiency, so they suffer from infections, they need IVIG for IG replacement, so all of the sort of standard of care that goes into doing that. But because many of these CVID patients also have autoimmune cytopenias, perhaps they might benefit from the care of a hematologist to help with that, or they might benefit from the care of a rheumatologist who can use certain kinds of immunomodulatory medicines to get rid of the autoimmune portion of the thing, while the immunologist is treating the immunodeficient portion of the thing. We're recognizing monogenic autoinflammatory diseases that show as one of their signs lymphoproliferation. So the oncologist gets called to think about malignancy, but the rheumatologist gets called to think about the autoinflammatory disease. And again, just sort of drawing from sort of recent cases, that we've had, ehrlichiosis as an infectious pathogen causing a fulminant HLH-like cytokine storm, right? So you clearly need an infectious disease doctor to help you with the diagnosis and management of ehrlichiosis, but perhaps you would benefit from a rheumatologist or an oncologist that can help manage your cytokine storm. The other kinds of issues we run into is what happens when you have multiple organ systems involved, right? So who owns it? Who is the quarterback taking care of leading the patient care team when both the brain and the gut are involved in the immune disease? And we've had many examples of, and you can name any two organs you want, brain and gut, lung and liver, joints and skin. Who owns it when you have, or sometimes there's 3 or 4 organs involved. Who owns it when there are multiple organs involved? Well, that's where the ology system breaks down, because you need more than one subspecialist. Who owns it when, for instance, the lung is a target organ, but the treatment is going to be a bone marrow transplant? So you clearly need a pulmonologist to diagnose and monitor and manage the pulmonary aspects of the disease, but the fundamental therapy is going to be something that's best handled by an oncologist. So there are lots of reasons why a multidisciplinary approach to immune patients makes sense, and trying to sort of break out of our old silos by creating essentially a new one, immune dysregulation, I think is helpful, and having a clinic then that brings together all these different expertises around immune dysregulation and all the things that could possibly happen is sort of an emerging paradigm for caring for these complex patients. So, maybe taking, as you heard from my sort of introductory bio, taking a condition that's sort of near and dear to my heart, the cytokine storm syndromes, and thinking about them for a little bit, you can, again, appreciate this spectrum, right? So cytokine storm is basically when the immune system goes completely haywire, produces copious amounts of cytokines, arming effector functions all throughout the body. You, again, get multi-organ failure, often results in death if not rapidly recognized and treated. And there are lots of ways of trying to break down what causes that process, what's driving that. So one way is thinking about what are environmental factors versus what are host factors that are driving the disease. And so in the case of environmental factors, well, just about anybody on this Blue Jeans call would end up getting sepsis if you had gram-negative rods in your blood, right? That doesn't require anything more than a particular environmental trigger. On the flip side, if any of us were to be completely deficient for perforin, we would get HLH. And doesn't really require a huge environmental trigger to set it off. And then there are a whole host of things that are in between: macrophage activation syndrome, immunodeficiency-associated cytokine storms, malignancy or EBV-associated cytokine storms, to varying degrees of environment and host that contribute to setting off the immune system and doing something incorrectly. And so already you're getting a sense that as we're thinking about cytokine storms, we're going to need oncologists and rheumatologists and infectious disease doctors, and likely many others, in terms of both diagnosis and treating the various things that can go on with the patients. And you can see how the different treatments might differ depending on what the trigger is and what types of physicians might be getting involved. To pick it apart, a little bit more closely, we often talk about these big buckets of HLH and MAS. And so in HLH or FHL, familial HLH, these are genetic mutations that result in the loss of perforin or perforin function, and disease usually presents in the first year of life. In contrast, macrophage activation syndrome is what is often used to call the same thing when it happens after a rheumatologic condition like systemic juvenile idiopathic arthritis or after infections or malignancies. And having these main buckets have allowed us to kind of tease apart the immunology a little bit and understand the immunology. And that's where I think, in the modern era, this gets exciting, because if we can understand these fundamental immune mechanisms, we can then develop targeted approaches to treating patients. So I think HLH is a great example of this, and so it's worth spending maybe a little bit of time thinking about it. As we said, it's a monogenic defect in cytotoxic granule exocytosis. So if you're missing perforin, so your cytotoxic granules can't kill because they're missing the effector molecule that's important for punching holes in the target cells, or you're missing any one of a number of these genes that's important for taking the perforin and excreting it out to the target cell to kill the target cell. So effectively, patients with HLH don't have a working perforin axis. Well, what does that do to an immune response? So from mice, we've been able to learn by using perforin knockout mice what actually goes on in an immune response when you're missing perforin. The normal immune response, you take some virus. In the case of mice, we use this canonical sort of model pathogen LCMV. The LCMV infects the mouse. It gets inside of an antigen-presenting cell. That antigen-presenting cell presents to a CD8 T cell, and that CD8 T cell gets excited by the LCMV antigen. And the CD8 T cell will do what CD8 T cells normally do. They'll make interferon gamma. And that interferon gamma, as an effector cytokine, gets the APC even more excited. So it's an even better antigen presenter to the CD8 T cell. So the CD8 T cell gets even more excited, and it makes interferon gamma once again. And so you have a feed-forward loop. And normally what breaks that feed-forward loop is the CD8 T cell itself, and it does this by shooting out perforin and killing the APC. You take away the stimulation, the CD8 T cell can now calm down because it's no longer being stimulated, and the immune response terminates. But if you're missing perforin because you're a knockout mouse or you're a human that's missing the gene for perforin, you can no longer kill that antigen-presenting cell. That signal continues and continues and continues. The CD8 T cell proliferates. You make an excessive amount of interferon gamma, and that's what drives the pathology in both the mice and the human. And the reason why all this work has been important is because we now have an FDA-approved medication that blocks interferon gamma that's indicated for the treatment of FHL. And so it's really a great example of where going after the fundamental immunology reveals therapeutic targets. Those therapeutic targets can be developed into drugs, and then those drugs end up actually working for the disease in hand. And so we're able, therefore, to treat our patients better, and they can benefit from from the fact that we actually can now recognize and go after their pathologic target. Of course, life's not that simple, right? So these things aren't always 100% clean or pure, right? Now, we know for sure that this does translate from mice to humans. We can look at gene transcripts, and we can show that, indeed, if you look at patients with HLH, you can see an upregulation of an interferon gamma signature that's not present in control patients. But if you look at the cytokines that HLH patients are making, the spectrum of cytokines is well beyond interferon gamma. And so it turns out that it's not always true that shutting down the interferon gamma is able to turn off the disease process, and that's not always true in mice, and unfortunately it's not always true in humans. And so, of course, then the search for additional targets needs to be made to try to figure out, well, in these patients aren't responding to interferon gamma blockade, are there other medicines that they can respond to? And so some of the work that we've done, in our own laboratory has revealed another important signaler for HLH, and that comes from the tissue damage itself that happens during the HLH process that releases another cytokine called IL-33 that is another way to turn on both CD4 and CD8 T cells to make them make more interferon gamma. And so there's this additional loop that involves IL-33 that we've been able to show in mice models is an important mediator of HLH as well. And if you neutralize and block IL-33, you can also cure the mice. And you can also cure the mice in an interferon gamma independent way, so that IL-33 covers other immune effector functions besides what I'm showing on this slide. And of course, IL-33 is now getting some recognition during the pandemic times, as this is one of the molecules that did show some initial benefits in treating COVID-19 patients in trying to quiet the hyperinflammation of COVID-19. So, we can learn about these other targets, again, by doing, this mouse research. And I think that sort of broadens the spectrum then of, A, the types of things that we might be interested in trying to diagnose in HLH, because you might want to measure interferon gamma, but you also might want to measure IL-33. And B, the types of therapeutic options we might have to treat patients, where some people might be great candidates for interferon gamma blockade, others might be better candidates for IL-33 blockade, others might be better candidates for IL-1 blockade, so on and so forth. The picture is equally as complex and growing in the case of multilineage cytopenia disorders, right? So when I was a resident, we talked about ITP, and then, if it got really complicated, maybe you talked about Evans syndrome, so you had more than one lineage down. And that was like the extent of our sophistication in thinking about autoimmune cytopenias. And with the advent of modern genomic and genetic analysis, we've been now able to recognize a number of genetic syndromes that are associated with autoimmune cytopenias. And as we do a much more sort of careful job in phenotyping some of our other immune syndromes, we're realizing that you can have autoimmune cytopenias as well as, for instance, an immunodeficiency like CVID. And so all these overlaps then begin to reveal themselves. And so this is, again, one sort of complicated figure to try to put things into buckets. You can think about immune dysregulation and hemophagocytic and lymphoproliferative syndromes associated with cytopenias. You can think about antibody and cellular mediated cytopenias. You can think about bone marrow failure syndromes. You can think about myelosuppressive syndromes. And, even in these buckets, there's overlap. And so the world of autoimmune cytopenia has rapidly expanded beyond the hematologist. It's not enough now to just be the hematologist and say you have Evans syndrome because your platelets and your hemoglobin are down. But you need to think about, well, do you have Evans syndrome because you have CVID associated with it? Or could I be missing one of these other conditions on this slide? And so, again, this sort of intersection of the disciplines arises and broadens the way in which we think about how our patients are presenting. So sort of taking ALPS as a canonical example, ALPS are traditionally genetic defects in FAS-mediated cellular death. So you get a lymphoproliferation because the lymphocytes don't die from FAS-dependent pathways. And the disease, as you can see, it's written on the slide, is associated with a host of different things. Autoimmune manifestations, malignancies. And so again, you're going to want a multidisciplinary team taking care of your ALPS patients to be able to screen for all the things that can go wrong with them and to think about the different types of medicines that might be, or therapies that might be used to try and mitigate some of those problems. Much like I was driving at for HLH, in the modern era, it is very worthwhile trying to figure out what the fundamental defect is. Because when you can figure out the fundamental defect, you can associate off-the-shelf therapy with it, okay? So for instance, if your defect is in antibody or B-cell development and you have CVID, treating that with B-cell-directed therapies like IVIG and rituximab helps. If your defect is a RASopathy and therefore you have a problem with MAP kinase signaling, there's a multitude of MAP kinase inhibitors available that you can use to shut that off. If you have a defect in the PI3 kinase pathway, you can treat with a PI3 kinase inhibitor. If you have a defect in regulating this molecule CTLA4, you can give back CTLA4 in the form of abatacept. If you have a defect in a signaling molecule, the IL-6 pathway, you can use an IL-6 blocking molecule to try and revert that. And so getting at these fundamental causes of the immune dysregulation syndrome, even when they can present with a whole host of different pathologies and organs involved. And so, if you look at some of the diagnoses on this slide, lupus can affect almost any organ. We talked about the different things that ALPS can affect. And so even with these divergent clinical presentations that really you can get with almost any of these diseases, understanding the molecular defect leads you to pick a particular therapy, and that can improve patient outcomes. So again, getting a sort of multidisciplinary team together, but a team that has an immunologic orientation to try and go after these fundamental causes often leads to being able to select rational therapy to treat the disease process. Sometimes we don't even know what the patient has. I know you've got immune dysregulation, I just don't know what it is, right? So you often will see patients that are clearly affected, their immune systems are clearly not working correctly, and you can tell that on the basis of functional studies, and yet they don't fit a known syndrome. And that's where, again, the modern era of genomics has often come to the rescue. So being able to no longer have to take 5 years to do positional cloning of some candidate gene to only find out that I'm wrong and that wasn't actually the causative gene, but instead look at every gene in the body through whole exome and now even whole genome studies, has allowed us to much more rapidly help patients that sort of fit into this N of one unknown category. It's still not easy to do, right? It's still not easy to do. I think you still need a good paired clinical and research team. And again, that's where these multidisciplinary immune dysregulation clinics really come into their own. But because the technology is now within reach of, most large research institutions, or not even large, but even, I would say most academic centers in the U.S., you can order a whole exome now clinically. It's no longer the purview of places like the NIH. But when you start to do that, you need to know what are you going to do with that information that you're getting. And that's where having the multidisciplinary research team and clinical team really comes into play. So why do we do this multidisciplinary thing? Well, the first is that every specialist that's needed gets involved. Nobody really sort of falls through the cracks. So if I can get together in one room the pulmonologist, the hepatologist, and the rheumatologist, then everybody gets to see you. You're not missing out on one important organ that is going to be crucial for your care. The diagnosis happens faster because the physicians are all together. We're all in the same room. We all get to talk to each other as we're seeing the patient. And putting all those brains together is certainly better than everybody operating in a silo. And then, maybe if you're lucky, the letter gets to you and you get to read what the other guy thought. So being together and working as a team expedites the way in which all the different subspecialists contribute to the care. The other thing is that we can sort of synergize between our recommendations to try and reduce polypharmacy and side effects by saying, well, I might have this choice of these 3 drugs for my thing, and you have a choice of those 2 interventions for your thing. Oh, but these 2 things are the same. They overlap. Why don't we pick that one particular drug? It'll get your thing and my thing at the same time. And so we can come up with a much more refined and I think targeted approach by leveraging everybody's expertise. And then finally, I think communication both between physicians but also between the patient and their physicians is much easier when there's a single point of contact. You don't need to know who to call if you're the patient if you have problem X. Do I need to call my rheumatologist or my oncologist? And you end up calling everybody, and then you end up getting different opinions or different opinions on different days. If you know, I just need to call the immune dysregulation clinic, and I have got my single point of contact for that, you're going to get the right answer from the right docs without having to worry about having to reach out and sort of get the whisper down the lane of, oh, no, it's not me, you need to call this guy. Oh, no, it's not me, you need to call this one. So I think it's a better experience for both the docs and for the patients when we can do this in a multidisciplinary way. All right, so what does immune dysregulation look like? So this, in some ways, this slide is obvious, and in other ways it's not, right? At the end of the day, immune dysregulation has to have some objective evidence of abnormal immune function. Something's got to be wrong with the immune system for you to want to suspect immune dysregulation. Now, that can come from labs, right? That can come from having an elevated sedator CRP, so documented evidence of systemic inflammation. It could come from abnormal immunoglobulins. So if you're hypogammaglobulinic, something's wrong with the immune system. Maybe it comes from objective documentation of having high fevers with no known source. But in one way or another, you're getting objective evidence of abnormal immune function from labs. The other way that you might come to this is objective evidence that there's inflammation of a target organ. So maybe there's a rash, or maybe there is hepatitis that you can see, or maybe there's a lymphadenopathy, so that you're palpating big lymph nodes, or maybe you're seeing cytopenias, so that the bone marrow seems to be targeted. But one way or the other, there is something that is connecting you to say, yes, my patient has a complex array of symptoms, but there's something associated with an immune problem that might be driving those symptoms. Because the trap is that you can have a lot of ways in which you can have these complex multi-organ syndromes like I've been describing and have nothing wrong with your immune system, in which case the last place you want your patient to go is to an immune dysregulation clinic, because we can't help the patient that doesn't have an immune problem at the source of their multi-organ, multidisciplinary disease. The other thing that often tips you off is that there's sort of more dysfunction than the expected, right? And I think, one of the things that I was struck by when we first started doing this was when our hematologists were saying, we've got all these Evans syndromes patients, and everyone, hematology is comfortable with Evans syndrome. That's what they do. But boy, they've got Evans syndrome, and then these other weird things, like this patient has a rash that I can never figure out, or they're complaining to me that my joints hurt, and I'm not a rheumatologist, I don't know how to examine a joint, but they clearly have Evans syndrome. Could those things be related so that it's more than just Evans syndrome? There's something else going on. And I would say that more generally, this comes in one of two ways. You can either have a more dense loss of function or gain of function than you might otherwise expect, right? Like a complete absence of a cell lineage. Like if you have absolutely no CD8 T cells, just as an example, I'm making something up, clearly that's something really wrong, right? That's not just run-of-the-mill whatever. There must be something fundamentally wrong with the immune system that's causing you to not have any CD8s or to not have any IgG at all, or to have too much IgG, right? So gain of function. When there's, or autonomous activity of an immune function, so that, you're always, your IL-1 is too high because you're always making too much IL-1. So you've got some autonomous activity of the inflammasome that's making you make too much IL-1. That often will make you suspect an immune dysregulation. The other thing that makes you suspect it is when you have two sort of disparate immune functions that aren't working. So you make autoantibodies, you've got a loss of tolerance, but you have a poor vaccine response. You can't actually respond to an exogenous challenge. So when you see those two things together, you think immune dysregulation. Or too much Th2-directed inflammation, a very atopic patient, but also increased infections that are well beyond what you might expect for instance, the skin breakdown of eczema. Maybe you have too many pneumonias that I can't explain on the basis of the Th2 inflammation. So when you have two disparate immune functions that are off, that often also leads you to immune dysregulation. And then we get to, I wrote down advanced diagnostics, and I'll admit that depending on your subspecialty and who's on this symposium, some of these may be more or less advanced to you. But I think one of the things that we are benefiting from is an explosion of different ways by which we can assess different immune effector functions. Now, the key to it is that we need to make sure that the labs that we're using are being done in a way that are reproducible and are validated against normal controls. And so trying to use CLIA-validated assays that are being performed in CAP-inspected labs, I think, is critically important. It's not always possible. Sometimes you will use research-based assays to try and get an answer for what you're looking for. But as much as we can, trying to use validated, certified laboratories is important. One of the things we suffer from is that a lot of the labs don't have normal ranges for children, depending on what assay you're looking at. And so I think, that's something that our community needs to begin to work on, which is understanding what normal ranges are for some of these measurements in the pediatric population. And I think the third bullet point is probably the most crucial. So interpreting the labs in the context of the entire presentation is always going to be required, particularly because of the second bullet point. If you don't know what's normal, then you need to at least be able to interpret the lab values in the context of your patient's disease presentation and the types of diagnoses that you're considering. And so, again, this is where the multidisciplinary specialized team comes into play in helping to understand what the diagnostics are actually trying to tell us. So measuring cytokines is certainly of a lot of use in a number of different conditions, because we know that certain immune dysregulation syndromes are associated with abnormalities in particular cytokines and not in others. It also allows you to determine the qualitative nature of the inflammation present in your patient when you don't have a predetermined set of cytokines you're looking for to make a diagnosis. If you can at least say, well, the Th1 axis is elevated, so I'm seeing lots of interferon gamma. I'm seeing lots of IL-12 versus the Th2 axis is elevated. Ooh, there's lots of IL-13 or IL-4 present. At least drives you to different qualitative immune processes rather than just saying, oh, your sed rate's up, you must be inflamed. So the cytokine panel does help figure out what qualitative aspects of the immune system are dysregulated. And often we can find cytokine panel patterns that lead us to specific diseases. One of the problems with advanced diagnostics is turnaround time. So often, you get an answer, but you get your answer back days later. And if you have a critically ill patient in front of you, that can be very difficult to have those data in an actionable time frame to actually make a decision. One of the ways that at CHOP we've dealt with this is we've rolled out our own cytokine panel that we can turn around in 24 hours. So if we have a critically ill patient, I can know what their cytokines are, usually by the next morning, in order to make a decision within a time frame that's actually actionable. And I think as we get more and more of these assays, we'll look to having more and more of the mindset of these are critical lab values. We need them performed in a critical turnaround time. There are a number of sort of single cytokine assays, even forgetting the panel, that let you probe dysfunction in particular pathways. Some of the examples I gave here are IL-18 and Cybele IL-2 receptor. And so, like, if you're looking for one of the so-called IL-18 opathies, NLRC4 being the canonical one, but there are other diseases of IL-18, you can look for elevated IL-18 in a single assay. Similarly, you can use Cybele IL-2 receptor to look for essentially what is activation of lymphocytes that has been associated with a number of different diseases, including HLH. And then finally, there are diagnostics that don't ask about the cytokine itself, but ask about whether the patient is experiencing the downstream effects of that cytokine. Are they functionally elevated for that particular cytokine? So for instance, interferon gamma is a great example where sometimes the interferon gamma is present and is active, but it's in the tissues and not in the blood. So trying to measure interferon gamma from the blood doesn't help you, but yet I can tell that the patient is overdriven for interferon gamma function if their CXCL9 levels are elevated, because that's a protein that is driven or that is made by interferon gamma's activity. So sometimes measuring not the cytokine itself, but the biomarker of the cytokine function is more informative. Similarly, for type 1 interferons, we can measure the interferon gamma gene, the interferon gene signature to let me know that this patient has an interferonopathy or an elevation or a increase of the interferon alpha axis. And so measuring not only the cytokines themselves, but the labs that lead us to be able to assess their function becomes important. Flow cytometry is a crucial tool in trying to understand immune dysregulation. It allows us to do a couple things. It allows us to assess both cell number, but it also allows us to assess activation status. So I can not only say you have too few or too many B cells, but if I have a flow cytometry panel that measures MHC class 2 levels on B cells, I can say that not only are those B cells increased in number, but they're activated, they're turned on. You can look at CD45RA-RO, for instance, as an example of do I have naive versus memory lymphocytes. And so you can assess not just number, but activation. And that's important because number doesn't always equate to function. There are many patients that have a normal number of CD4 T cells, but those CD4 T cells are doing something they shouldn't be doing. They're either activated or they're not acquiring memory status, so on and so forth. Again, this will be where you want to have somebody on your team who has expertise in understanding what all the different markers and combination of markers mean for immune function. You can profile the humoral response. So you can ask questions about amount of antibody being made, isotype of antibody being made, and the specificity of the antibodies that are being made. So we can use diphtheria and tetanus to look at protein specificities. We can use pneumococcal responses to look at carbohydrate specificities. And once again, either too much or too little can be the sign of a problem. So you have a patient that can make protein specificities but not carbohydrate specificities that lead you down into specific antibody deficiency and other defects that prevent you from making T-independent B-cell responses, and so on and so forth. And once again, the answer isn't always in the serum. Sometimes you have to worry about either tissue-bound antibody or the surface immunoglobulin patterns on B cells. And so, like, for instance, IgG4-related disease is another sort of immune dysregulation syndrome. Often the IgG4 will be completely normal in the serum, but if you can get a piece of tissue that's affected, you can see that the plasma cells are all uniformly IgG4 positive in the tissue. So, considering not just what's going on in the serum or the plasma, but remembering that we need to look in the tissues sometimes where the organs are being infected is important. And then finally, genetics, has really sort of revolutionized this. And there are lots of ways of approaching this. I mean, the genetics of immune dysregulation, quite frankly, could be an hour-long talk right there. If your phenotype is specific enough, we will start with targeted panels. So if we know we're thinking about things in the autoinflammatory category, we can do an autoinflammatory gene panel. If we suspect a genetic cause, but the phenotype does not suspect a particular panel, that's where the whole exome becomes important. And these are really much easier interpreted if you can do the trio. So if you have both mother and father, to allow you to look for de novo genes, to allow you to look for autosomal recessive genes, having that trio becomes crucial in really being able to interpret the whole exome. And then finally, deletion duplication studies become important in the workup of unknown variants, because it may be that if the exome detects a particular variant that might be pathogenic, what exomes are not so good at are looking for deletions, for instance. So you might have a pathogenic variant that is accompanied by a deletion on the other chromosome. Following up your sequencing assays with del-dup assays to look for copy number variation becomes critically important. The bugaboo of all of this is the variants of unknown significance. And you almost always get one variant of unknown significance in your study. And sometimes these are critically important. Sometimes these are actually the answer, right? These are genetic variants that have not yet been associated with a particular disease, but are present in the patient and are either like de novo, therefore are not in either parent and therefore of interest, or have such a slow to non-existent allelic frequency in the normal population that you suspect that maybe the variant is important. But there's not enough information in the literature to say, that's the causal variant or not. These really require significant expertise to interpret. You need to have people that know the gene function. You need to have people that understand the physiology to comment whether these are important to pursue or not. And they often will require a research level validation, expressing the variant, seeing whether the variant results in protein instability and therefore differences in protein levels, seeing whether the variant has normal protein levels but abnormal function. And they can require, a significant amount of work. But again, when you have a dedicated team to immune dysregulation that includes not just the clinical side but the research side, you're able to leverage this and often actually find causal variants that often, again, suggest rational targeted therapies, because if you can know the gene, you can often pick an off-the-shelf drug that addresses that genetic dysfunction. All right, so when is it not immune dysregulation? And I would say the biggest thing that comes to us is that the patients may have multi-organ or sort of vague symptoms, and it often takes the form of things like fatigue or musculoskeletal pain or brain fog or changes in behavior, or just this is a diagnostic challenge, I can't figure out what's going on. But there isn't one of these things we just mentioned that is clearly pointing to, yes, the immune system isn't working right in some way or the other. So, brain fog and fatigue, but no fevers, SED rate is normal, CRP is normal, so on and so forth. And, I would say that the immune system is not the best poker player. Usually when it's driving something that is severe enough to cause a multi-organ problem, it reveals itself. We might not understand what's going on. We might not understand what the fundamental defect is, but usually there's something wrong. Either your SED rate is high, or your IgG is low, or I can measure some component of the immune system that tells me, yes, there's an immune problem that explains all these other symptoms. Inflammation is not necessarily a subtle thing. It is, the immune system is turned on, and you get heat, and you get swelling, and you get redness because these blood vessels are dilating and you're seeing inflammation. You can have different flavors of inflammation. You can have different T cells that are activated. You can have complement driving inflammation. You can have innate cytokines inflammation. Inflammation could be systemic or it could be local. But inevitably, you can find it. If it's systemic, you'll find it in a CRP or a SED rate. If it's local, when you biopsy that organ, you'll see inflammatory cells in that organ. Pain, as a complaint, doesn't always equal inflammation, right? So pain, often people will say, oh man, my knee is really inflamed today. It's hurting me so bad. But that doesn't necessarily mean the knee is inflamed. If I took a baseball bat and smashed your knee, it would hurt, but it's not necessarily inflamed. It's just injured. It's traumatized. And likewise, there are lots of ways you can get pain that have nothing to do with immune activation. So what is it when it's not immune dysregulation? And I would say the number one diagnosis that we see in the immune dysregulation clinic when it's not immune dysregulation is amplified musculoskeletal pain syndrome. It's a central sensitization to pain that results from a combination of altered neurovascular dynamics and psychosocial stressors. And the treatment has nothing to do with modulating the immune system. It has to do with physical therapy and stress management and demedicalization. And there's an entirely other multidisciplinary clinic at CHOP that handles these patients and can do quite well with them and treat them. But it's not immune dysregulation. And the clue is these patients have normal labs. They have normal radiologic studies. They have normal biopsies if they've had biopsies. There's no evidence for inflammation, despite the fact that they have these multidisciplinary, multi-organ complaints. And that's not, they're not going to be helped by our clinic. When we can make the diagnosis and move them to the right clinic, that's great. But even better would be to direct them to the right physicians in the first place. So AMPS is really an umbrella diagnosis for a whole host of different conditions that go by a million different names. That's not important. Really, what's important is that at the end of the day, they're all diseases of central sensitization and amplification of the neural signaling that elicits pain hypersensitivity. So under normal neural function, you get pain because the nociceptors receive some stimulus that causes them to fire and drives a pain signal that goes to your brain. Likewise, if you're tickled with a light feather, a different set of nerves fires and signals this as being light touch. And in AMPS, the wires get crossed so that these toxic stimuli produce an increased pain response called hyperalgesia, but now the tickle from the feather also crosses over into the pain nerves and gives you allodynia, where you're experiencing pain to a stimulus that otherwise shouldn't cause you pain. And that produces hyperesthesia. And as an example, this is what a child draws as their symptoms in the midst of a amplified pain flare, and you can see all the places that the child is hurting and all the different kinds of pain that they have, and it's quite severe, and it would appear at first blush to affect all sorts of different places and organs and functions of this patient that might make one think that maybe there is an immune dysregulation syndrome involved. But when you measure and you look, the immune system is normal, and therefore it can't be an immune dysregulation syndrome. It really belongs in an amplified pain clinic. The other thing that we often see are these sort of diagnostic challenges, multi-system complaints happening in the absence of an immune etiology, but not amplified pain. So connective tissue disease is one example. You might have genetic mutations of collagens or elastin genes. And although sort of in the older textbooks, people connect connective tissue disease to rheumatic disease, that's not really the case. These are really genetic diseases. These are diseases that belong in the geneticist's clinic, and things like Ehlers-Danlos or Marfan syndrome, where you can have multiple organs involved, but it's not a fundamental inflammatory process. And then metabolic or mitochondrial disease, these can be tricky because they can have some immune overlap. Sometimes having a metabolic or mitochondrial problem does actually cause the immune system to be activated, but at its fundamental basis, it's not an immune dysregulation problem. It's a problem of metabolic dysfunction, and if you attack that fundamental issue, that's how you can make the disease get better. And so, again, it's not a problem when patients with these conditions come to our immune dysregulation clinic. We often are able to identify where they need to go. But with respect to sort of the referring physicians, if we can take the initial steps to decide, yes, I see immune activation, or no, I don't, often you might get somebody to their correct clinic faster, rather than referring somebody to immune dysregulation when it's fundamentally not that in the first place. The other main thing that I would say is that this doesn't supersede sort of the classic silos of immune disease. A patient with lupus needs a rheumatologist. Yes, it might be multi-organ, but at the end of the day, it's going to get taken care of much more efficiently, much more rapidly if you send that patient to a rheumatologist. If you have a cancer, go see the oncologist. You don't need, me or the pulmonologist or what have you. The first thing you need is to get and go and see an oncologist, and they can direct the team. If you have specific antibody deficiency, that's managed by an immunologist. You don't necessarily need an entire immune dysregulation team to take care of that. So this isn't to sort of supersede or replace these sort of classic silos of immune disease, but rather to catch everybody else that fits between those cracks, that doesn't fit into one of those diagnoses. All right. So I think we can end with just a couple of examples, a couple of case presentations, and then we can take some questions. So as an example of an immune dysregulation condition, this was a 26-year-old that 9 months prior to presentation developed a nephrotic syndrome, and at the time was found to be EBV viremic, but his the physicians taking care of him didn't sort of put those two things together and just said, well, that's curious. You're just kind of sick from your nephrotic syndrome, and treated him as such. 9 months later, presents with pancytopenia, high ferritin, big liver and spleen, and elevated soluble 2 receptor. His outside hospital diagnosed him with EBV HLH because he remained EBV viremic and started him on a protocol for EBV HLH. However, they consulted with our team, and we asked for a few labs, and what we realized very quickly is that this isn't just your run-of-the-mill EBV HLH, that this was a profound B-cell dysfunction, because the patient had no B cells in the peripheral blood, and that was prior to rituximab. So the patient was given a B-cell depleting therapy, even though the patient didn't have any B cells to begin with. And on top of that, when we looked at the original bone marrow that was done months and months earlier, we realized that there were no B-cell precursors in that bone marrow. So once we recognized that this was actually a B-cell immune dysfunction syndrome, the patient was transferred to CHOP, and we do take care of the young adult population as well with this. Because we find that there are not colleagues in the adult side that have as much expertise. We realized that the EBV had an altered tropism rather than infecting the B cells, which weren't present. It was actually infecting the NK and T cells, which is a pattern that we see in chronic active EBV infections. We did a whole exome sequencing and found a variant of unknown significance that we believe to be the causal genetic variant, which suggested that bone marrow transplant was the appropriate therapy. And so we were able to successfully get this patient to a bone marrow transplant. So this is an example of a patient that had lots of different organs: nephrotic syndrome, kidney, big liver and spleen, lymphoproliferation, HLH-looking condition with the high ferritin, EBV viremia. But when one takes a closer look in profiling the immune system, you can see that there's a very specific compartment that was abnormal in the B cells. Genetic analysis brings a causative gene, and then we're able to sort of get the patient definitive therapy in the form of a bone marrow. Another example was a 20-year-old with what had been called sarcoidosis by the primary team for many years, lesions that had granulomatous inflammation, and was treated with a TNF-alpha inhibitor that was mostly affecting skin and lungs. However, eventually was found to become hypogammaglobulinemic that required IVIG replacement, and then neurologic disease in the form of headache and dizziness and ataxia, and an abnormal MRI. At the same time, developed a significant thrombocytopenia. Now, again, we've got lots of multiple organs. This granulomatous disease, it's also associated with a CVID. This is clearly an immune dysregulation syndrome. We did whole exome sequencing and could not find a variant here that we thought would be of interest. But because the description of the disease sounded so much like CTLA-4 deficiency, on a research basis, we stained her cells for CTLA-4, and basically there was a complete loss of CTLA-4. We've not identified the genetic defect yet that is driving that, but given that presentation and given that immune finding, treated as if this were a CTLA-4 deficient patient with steroids and abatacept, and has ultimately resulted in a resolution of her symptoms. So those are just sort of a couple examples of how you kind of get to an immune dysregulation phenotype, multi-organ, clear elements of the immune system that are dysregulated or dysfunctional. We may not know the disease at first blush, but going through the workup, doing all the advanced diagnostics lets us get to a more specific immune diagnosis that often suggests a definitive therapy. So when to refer for immune dysregulation? When there's objective evidence of immune activation, right? So I think there needs to be some reason why you suspect the immune system. It's not enough to just have fatigue, malaise, and nothing else that would suggest the immune system. There needs to be at least something that suggests the immune system. I think patients that have multi-system involvement benefit from our approach. And then there should not be some otherwise clearly defined syndrome for which referral to a traditional subspecialist would be warranted, right? So if your question was, does my patient have lupus? Refer straight to the rheumatologist. Don't refer to the immune dysregulation. If your question is, does my patient have leukemia? Refer to the oncologist. Don't refer to the immune dysregulation clinic. But when it's clearly none of those things to you, but yet you have this complex multi-system presentation and at least one piece of evidence that makes you think immune activation, that's the perfect patient for an immune dysregulation workup. So I'm going to stop here and turn it over to my colleagues on the national provider engagement team, who can explain, how we might be able to help, no matter where you are in the country, in order to get patients with immune dysregulation and other conditions evaluations at CHOP. So I'm going to turn it over to Zach.
Thank you so much, Dr. Behrens, for the fantastic lecture. So we'll get the Q&A in one moment. We just wanted to close with sort of 2 slides about how we can keep the conversation going and opportunities to continue collaborating. As you can see here, and we will share some of these resources. CHOP does post many, if not all, of our evidence-based clinical pathways to our website. So we would encourage folks to go and look there. There's several pathways that Ed and the team have actually collaborated on during COVID that have been published here. We're also going to be hosting a lot more virtual education. So if you're interested in signing up for additional CME lectures, we'd encourage you to go browse what we have coming up. We have some exciting lectures planned over the next 6 to 8 months. And Ed, can you go to the next slide? And just looking at the registration list, we're thrilled that we've helped to share this message with institutions that cover across 27 different countries on today's lecture. And here within the United States, we have 29 different states represented. So we would love to keep this dialogue going with you, whether that would be getting in touch about a patient, if you're looking for more information, you'd like to arrange some follow-up education within your own institution, or need support on a referral. We do have specific teams that can help you. So whether you're here in our local area, for our national partners or our international partners, some of the information you can see here is sort of how to stay in touch and how to keep the conversation going. And I think we can now shift to question and answers. In the view that you can see, there is a question and answer button. We would encourage you to sort of put your questions in, and we will start going through them in the time that remains.
Great. So I see some questions coming through. The first one that we have is, Ed, if somebody wanted to, or if a group of providers wanted to improve multidisciplinary care for these particular types of patients at their hospital, are there 2 or 3 key recommendations that you would give on how to get started?
Yeah, so, I think just having been through the process myself, it requires, I guess, a couple of key things, I think, to get started. The first is that, you really got to have truly interested parties from each of the subspecialties you want to pull in. And I think, kind of the core group maybe is rheumatology, immunology, oncology. And if you can identify just one person that says that, yeah, this is what I want to take on, this is what I want to do, get that team together, and that's where you start. You begin to think about, okay, can we create a clinic where we will see patients together? What kind of pathways and standardization of care do we want to have for our institution? The way it sort of started here at CHOP is we wanted to standardize the way we treated HLH. And it was just that one specific question. It wasn't really anything bigger or broader that like we were talking about today, but just how can we do better for HLH at CHOP? And we got a couple of different subspecialists from each of the different subspecialties involved, and we just worked on pathways for HLH. And then we said, you know what, we could do this even bigger and better and broader for other patient problems as well. So I think it really comes down to having the right people that are truly interested in the process and are going to be effective partners, and then you build from there.
Great. With respect to looking for the smoke when there's fire, what guidance can you offer for testing for various aspects of immune dysfunction?
So they're often not like, sometimes it's completely random, right? Like I'm always amazed at how, like, what can go wrong will go wrong. But I would say it's often related functions, right? So a patient with autoimmunity, is making some autoantibody to whatever. But you're like, oh, there's something odd about it. This feels weird. This doesn't feel just like my run-of-the-mill autoimmune cytopenia is a classic example, but you can, like, autoimmune hepatitis, pick the organ that's being affected. Searching for immunodeficient defects on the humoral immune side then becomes sort of interesting, right? Like, so measuring vaccine responses, measuring immunoglobulin levels. Sometimes you might not think to do it if you my patient already has an smooth muscle antibody, so it's just autoimmune hepatitis, until you realize that it's not just autoimmune hepatitis. It's autoimmune hepatitis being accompanied by hypogam and a poor vaccine response, and that's when it becomes something more, right? So you can imagine on the T cell side, a patient who is having recurrent viral infections or something. And then, you look for T cell function and realize that there's a defect in T cell maturation or T cell numbers or something. So I think this, where there's smoke, there's fire kind of thing is to say, it's interesting what you find when you start thinking more broadly, right? So if you find that there's something wrong with one aspect of the immune system, work up all the other pieces that go along with that aspect of the immune system, because you might find dysfunction that you didn't recognize in other spots.
Did you have the opportunity to look at IL-33 blockade with and without IFNG blockade in preclinical models?
So in preclinical models, it works beautifully. So if you give IL-33 blockade to HLH mice, they're basically cured, as well as if they're cured from an interferon gamma blockade. And then if we tweak the system in various ways to make it where interferon gamma blockade no longer works for various reasons, IL-33 blockade still works even in those scenarios. So actually, we were really bullish on IL-33 blockade on the basis of preclinical models for HLH. At the time, I tried to pitch this to a couple of pharmaceutical companies that had IL-33 products for patients. Because it's more of a Th2 directing cytokine, they're very interested in developing it for asthma. And they did not want to jeopardize their asthma programs by using it in patients where there's a high mortality rate like HLH. And so I could not convince any pharma to try and look at IL-33 blockade in patients. Of course, once COVID-19 came along, everyone sort of changed their mind, and I think they began using it in those scenarios. And there was at least some preliminary data that was interesting. We'll need to see where it plays out. But I think that IL-33 blockade is viable because there are antibodies that have already passed phase 1 and phase 2 trials. And so the question is, again, I think getting a willing partner that would be interested in actually looking in human disease populations to see whether that would be a viable way forward.
How do you deal with a VUS in immunological genes?
It goes through a couple of stages, I guess, of triage. So if there's a VUS in the clinical report, first thing we'll do is we'll look at the gene. Does the gene make sense? Could it be a viable story for what's going on in the patient? Does the variant make sense? Is the variant predicted to be pathogenic by using things like SIFT and polyphene and other algorithms to say, that's an amino acid change that would cause a problem? What's the allelic frequency in the general population by looking at tools like Nomad? If it sort of reaches the bar to where, it is of interest because of those things, then we try to see whether there's anybody already on campus or that we know that we could collaborate with that's already working on that gene that might be interested in looking at that variant. And if we can, at that point in time, establish that the variant is doing something meaningful, that's how we can sort of move it on. The other way that we get VUS is that what we try to do on a research basis, and so most of the patients that we see get consented onto our protocol. If you have a clinically negative exome, we'll try to get those data and actually do a exome board research review, again, to look for variants that don't make the cut for a clinical call because they're not, validated variants enough that people feel comfortable reporting out as a clinical possible hits. But on a research basis, you often will find genes that become of interest that you can then take through the same process, right? And if you can get it to the lab and at least show that your variant causes a problem in protein stability, protein levels, or that the variant causes a defect in RNA levels, that's often the easiest first clue. It becomes harder when protein and RNA is normal, and then you've got to try and show function, but you often are able to, not often, but sometimes you are able to show that function is abnormal, and if you can do that, then it becomes sort of worthy of moving it on to the next stages. But I think this is the biggest problem of our times, right? Like all the VUSs, you're convinced that this patient has got something something genetic, and how do we rapidly move from a VUS to something that's a little bit more of a known significance, I think is the problem of our times. There are people that are working on sort of high throughput ways of doing this, but I think that that's going to be, some years away before we can just sort of chuck a variant into sort of a large screen and say, oh yeah, that's real or that's not real.
For a patient with known or suspected immune dysregulation syndrome, do you have a standard surveillance protocol to assess for possible other autoimmune conditions affecting other organ systems, or is this symptom driven?
I would say it's a little bit of each. I think it's certainly symptom driven. But I think, this is where I will say this is where the multidisciplinary thing is so awesome. Because number one, I'm like a million times better doctor now than I was even like 2 years ago before I started doing this, because I just learned so much from my colleagues. And what you learn is how we all do a slightly different review of systems, how we all do a slightly different HPI, and how we all do a slightly different physical exam. And I would say in many ways, like that makes our surveillance much more powerful, because our hematologist on the team is going to ask different questions than I do. And I'm going to ask different questions than the immunologist does, who's going to ask different questions than the infectious disease doctor does. And by the time you finish with all of those HPIs and review of systems, you've done a pretty good surveillance, and you'll be shocked by what you dig up, right? Like symptoms or questions that I just wouldn't have asked, that somebody else asks, and then the patient answers in the positive, and then you work that up. And that's sort of how we do the surveillance. So I think part of the way we do effective surveillance is by having this very multidisciplinary approach to these patients, essentially assuming nothing, right? Assuming nothing. You need to see all these different people, because who knows what's actually going on, and if I don't ask the right questions, I'm not going to find it. So that I would say is the strongest part of our surveillance, is the multidisciplinary aspect.
Sometimes it takes 1 to 2 months to get genetic testing results. Would you start empirical treatment if phenotype is not typical to any certain mutation?
That's a very patient-specific question. And I think we probably do different things for different patients. But we do sometimes end up having to do empiric treatment because the patient is sick enough, because the symptoms are severe enough, and often what we try to do is, I think, as you're sort of suggesting, try to draw a parallel for what it looks like the most clinically, and say, well, this feels like a periodic fever syndrome, and it feels FMF-like, so we're going to try some colchicine. We do sometimes do that. We prefer to try and get as much data as we can before we make the decision to start empirical therapy. That often will come in the form of more functional immune testing that comes back quicker. So certainly, I might want to know what your cytokines look like, what your cell populations look like, so I at least can have a sense of what targets I'm going after. But there are times when you have to start empiric therapy before you get your genetic testing back. I think it depends on each individual situation.
Are there any translational lessons from the immune dysregulation work that has helped with COVID?
I think in the beginning of it all, there was a lot of excitement about this being a hyperinflammatory disease and a cytokine storm, and people were trying tocilizumab, and people were trying IL-1 blockade, and the larger scale studies have sort of tampered or dampened enthusiasm for some of that stuff. I suspect if we could find the right subpopulations, the right directed therapies would work for the right COVID patients. But I think the place where it really helped us in particular to be prepared was for the MIS-C presentation in children. So when that was sort of first hitting the scene, our team was ready and prepared to think about how the intersection between the immune system and COVID infections might cause problems for patients. And we were immediately able to jump on it and leverage some of the things that we've already been doing for other immune dysregulation patients, like cytokine panels, like other types of immune assays, to help us, A, make the diagnosis more specifically, and B, again, think about what kinds of therapies that we would want to use. And so, even in infections, right, there's an immune response that's part of the infectious presentation. And so I would argue that even in infectious disease problems, having the immune dysregulation approach can be helpful both diagnostically and therapeutically.
Great. I think that's it on the question. So Ed, any final remarks before I close this out?
No, just to say thank you everybody for tuning in. I'm flattered that you all wanted to come and hear the talk today. And as was pointed out, if you guys have other questions, specific patients you want to discuss, there's that contact information there. Please feel free to reach out. Our team is happy to collaborate with anybody and everybody.
Just a final reminder, please fill out your post-event surveys before Friday, November 6th. If you have any questions following this event or would like to access the link to the recording, send us a note and we would be happy to connect you to the resources that are needed from you and your team. Thanks so much again for attending. Take care.